Hi, everyone. Welcome to the 39th session of the Transnational Vascular Interventional Radiology Journal Club. We are an open access virtual initiative to educate trainees on clinical research studies pertinent to VIR through monthly journal club sessions. Each TNVIRJC session focuses on a randomized clinical trial or a meta-analysis, so like level 1 evidence, accompanied by an overview of the relevant disease and interventions. Today we're going to be having Dave Enriquez and Shiva Morisetty present on the Checkmate 9DW trial. You can go ahead and start.
Hi, good evening, everybody. My name is Dr. Shiva Morisetty, and currently I'm a transitional year resident at HCA Westside in South Florida, and I'm committed to matching into radiology this upcoming cycle.
All right, how's it going, everybody? My name is Dave Enriquez. I'm a third-year medical student at University of California, Riverside School of Medicine, and in 2 years, I'm committed to matching into radiology as well.
Okay, let's start. Next slide, please. Okay, so these are our learning objectives. So we'll begin by talking about the statistics of liver cancer and explore the pathophysiology. And we'll go on into the relevant pharmacology, and then we'll explore the 9DW article. Next slide, please. Yes, let's talk about the disclosures and the study funding. 9DW was funded by Bristol Myers Squibb, which is a global biopharmaceutical company known for manufacturing pharmaceuticals and biologics in various therapeutic areas such as cancer, HIV and AIDS, cardiovascular disease, diabetes mellitus, hepatitis, rheumatoid arthritis, and certain psychiatric conditions. Several of the authors are employees of BMS or report relationships with the sponsor. So that is a potential source of bias that we should keep in mind as we move forward and review the article. For those of you who are MS1s and MS2s, it's important to note that Cochrane Review states that industry-sponsored trials are more likely to report favorable results and conclusions than non-industry trials. And this will be on step 1 and step 2. So keep that in mind. Next slide, please. Yeah, so what's the purpose of 9DW? Why are we interested in this article? The purpose is really to report the results of the pre-planned interim analysis of Checkmate 9DW, which evaluates the safety and effectiveness of using nivolumab and ipilimumab versus monotherapy with levatinib or sorafenib for the treatment of unresectable hepatocellular carcinoma in the first-line setting. The preferred treatment at this time for HCC with portal invasion is atezolizumab and bevacizumab, which has displayed an overall survival benefit over monotherapy with tyrosine kinase inhibitors such as sorafenib or lenvatinib, as indicated by this visual on the right side of the screen. And in certain cases, we can consider secondary treatment with other tyrosine kinase inhibitors. Next slide, please.
All right, so just a quick question for everybody. So what's the percentage of total cases of liver cancer that are comprised of hepatocellular carcinoma? We'll go ahead and take 30 seconds for everyone to answer. All right, we can go ahead to the next slide, please. Okay, so background on the overview of hepatocellular carcinoma. So liver cancer is the 6th most common cancer and the 3rd leading cause of cancer-related death worldwide, accounting for 800,000 deaths in 2022 alone. Globally, new cases are predicted to increase by 55% between 2020 and 2040 per year. Hepatocellular carcinoma accounts for up to 85% of cases of liver cancer with a 5-year survival rate for advanced disease, typically below 5%. Multi-kinase inhibitors, such as sorafenib and levatinib, were considered first-line treatment options for patients with unresectable HCC until 2020, when the results of the IM-BRAVE 150 trial were released, which Shiva will explain further in the upcoming slides later on. The American Cancer Society predicts that roughly 42,200 new cases will be diagnosed throughout 2025, and the death rate is above 30,000 people every year. So this is a leading cause of morbidity and mortality in the US. So just to highlight, incidence and prevalence rate are very common topics in USMLE Step 1. Next slide, please. So incidence and mortality rates for liver and intrahepatic bile duct cancer over time. The following two death rate and incidence rate curves are pulled from the latest data from American Cancer Society and are age-related adjusted to the 2000 US standard population. Overall, males are more highly affected than females. However, the incident rate has increased steadily over the past 40 years, affecting both sexes. Next slide, please. And in the US, starting in the early 1960s, males have had a higher mortality rate, which has steadily increased since then. Next one, please. Next slide, please. Awesome. So pathophysiology of HCC. All primary liver cancers, especially HCC, tend to arise in the setting of chronic liver injury. The cycle is simple but destructive. Inflammation, hepatocyte necrosis, and regeneration over years leads to nodular cirrhosis. In cirrhosis, ongoing oxidative stress, DNA mutations, and fibrotic remodeling create the setup for malignant transformation. Angiogenesis through vascular endothelial growth factor, VEGF, fuels growth. So cirrhosis, regardless of the cause, is the single strongest risk factor for liver cancer. Next slide, please. Okay, so this slide has a lot going on it, but it's pretty much an illustration of the concept we just talked about, with more detail included as far as molecular involvement. I just wanted to point out insults to the healthy liver, which can eventually lead to HCC, which is typically a progressive process with extensive immune dysregulation. So if you guys actually look at the leftmost box, so these are like the typical insults. You have hepatitis B, hepatitis C, toxins, and autoimmune diseases. And they lead to the third box to your right with like reduced antigen presentation, reduced stimulatory cytokines, and increased inhibitory cytokines. And the whole point of it is that there's less surveillance. Okay, next slide, please. Cool. So we have the subtypes of primary liver cancer. So primary liver cancers fall into several subtypes. The most common by far is hepatocellular carcinoma arising from hepatocytes, usually in cirrhotic livers. Cholangiocarcinoma from bile duct epithelium makes up to about 10 to 15%. And its risks include primary sclerosing cholangitis, chronic biliary inflammation, and liver fluke infections. We also have rare subtypes, which include fibrolamellar HCC, hepatic angiosarcoma, which is linked to bile chloride or arsenic exposure. And then you also have mixed tumors that show both hepatocellular and cholangiocellular features. Next slide, please. And then how would you characterize HCC? So now we can narrow down our perspective to hepatocellular carcinoma specifically, which is the focus of our presentation. Risk factors are those you would typically expect from reading first aid: chronic hepatitis B and C, chronic alcohol abuse, and non-alcoholic steatohepatitis. So HBV is unique because it not only causes inflammation, but it also integrates its DNA into the host genome, promoting direct oncogenesis. And then you also have environmental toxins like aflatoxin inducing mutations at p53. And then you also have cirrhosis, which is present in about 80% of cases. On the genetic level, p53 loss, beta-catenin activation, and TERT promoter mutations are key drivers to the pathogenesis of HCC. Clinically, HCC often remains silent until late-stage disease. You have alpha-fetoprotein is the classic lab marker, but it's not specific. A hallmark is its tendency to invade hepatic and portal veins, which worsens thrombosis. Next slide, please. And then we'll talk about the pathogenesis and its microenvironment. So pathogenesis begins with chronic inflammation and cyclical liver cell injury, and repair is the hallmark. leading to dysplastic nodules that eventually progress to carcinoma. Angiogenesis, largely driven by VEGF, is crucial for tumor growth. The tumor microenvironment is immunosuppressive, with regulatory T cells and myeloid-derived suppressor cells, as well as inhibitory cytokines like IL-10 and then TGF-beta. On top of this, the tumor upregulates checkpoint pathways like PD-1, PD-L1, and CTLA-4, which essentially puts T cells to sleep, allowing for immune evasion. Next slide, please. Okay, now about clinical behavior. Clinically, HCC behaves very aggressively, with high recurrence and metastasis rates, most often intrahepatically, including vascular invasion to the portal vein, and also the lungs and the bone. Prognosis depends not just on the cancer itself, but on liver function and performance status, since cirrhosis limits tolerance for therapies. This is why stratification in clinical trials uses measures like the Child-Pugh score, ECOG, and the Barcelona Clinic liver cancer staging system. And handing it off to Shiva for the next slide.
Yeah, thanks, Dave. So, yeah, I really just threw this slide in as more of a reference to what's occurring at the histological level. So, if we follow this table to the right, then and correlate it to the image, we can see that in the top left box, we see a well-differentiated G1 lesion, where we can see that most of the cells are still pretty uniform in appearance. And the top right shows a moderately differentiated HCC, and the bottom left displays poorly differentiated cells, and this would be considered grade 3. And the bottom right shows grade 4 cancer, and this would be the worst histological subtype. Next slide, please.
All right, so now talking about the pharmacology, the immune checkpoint inhibitors. So checkpoint pathways are natural brakes on T cells to prevent autoimmunity. So PD-1 acts in the tumor microenvironment, shutting down active T cells when it binds PD-L1. CTLA-4 works earlier at the priming stage, reducing new T cell activation. Drugs like nivolumab and ipilimumab block these pathways. The key difference from kinase inhibitors is that immune checkpoint inhibitors, ICIs, don't just suppress growth. They can restore lasting immune memory against a tumor, leading to durable responses. Next slide, please. All right. Now focusing in on nivolumab. Nivolumab is a PD-1 inhibitor, an IgG4 monoclonal antibody that blocks PD-1 on T cells, preventing the inhibitory signal from PD-L1 expressing tumor or immune cells. This restores T cell activity against tumor antigens. In Checkmate 9DW, it was dosed at 1 milligram per kilogram every 3 weeks for 4 doses. Then switched to a flat 480 milligrams every 4 weeks. The trade-off for an increased immune response is immune-related adverse side effects like colitis, hepatitis, pneumonitis, and endocrine disorders. All right, next slide, please. Now for ipilimumab. Ipilimumab is an IgG1 monoclonal antibody which functions as a CTLA-4 inhibitor. By blocking CTLA-4, it enhances early T cell priming in the lymph nodes, creating more tumor-specific T cells. When combined with nivolumab, you get both broader priming and stronger activation, which is why dual checkpoint inhibition can be more effective. The price, however, is toxicity. Ipilimumab tends to cause more immune-related adverse events, especially dermatitis, hepatitis, and colitis. Okay, next slide, please. Perfect. So, and then now we have sorafenib, which is a multi-kinase inhibitor that blocks vascular endothelial growth factor receptors, VEGFR, platelet-derived growth factor receptors, and the RAF pathway. It was first approved at 2007, and it was the first systemic therapy for HCC. Median overall survival was about 12 months. Toxicities, though, are tough for patients. You get hand-foot skin reaction, diarrhea, and hypertension are common and limit tolerability. Next slide, please. Now, levatinib is another oral multi-kinase inhibitor with activity against VEGFR, fibroblast growth factor receptor, PDGFR, RET, and KIT. In the REFLECT trial, it was shown to be non-inferior to sorafenib with a median overall survival of 13.6 months. Side effects overlap, but include hypertension, proteinuria, diarrhea, and fatigue. Cool. Next slide, please. All right, so just to give us a good framing for the rest of the discussion, I just want to go ahead and summarize some of the relevant biostats for this presentation. So the first one is overall survival. So pretty much it's time from randomization to death from any cause. It's like the most direct measure of how long patients live after therapy, regardless of disease progression or other causes. And then you also have progression-free survival, PFS. It's time to first radiologic progression or death, or whichever comes first, using the RECIST criteria or the mRECIST criteria in HCC. Essentially, it measures how long a therapy can keep the cancer under control before it worsens. Next, you have the objective response rate. It's essentially the percent with complete response or partial response to treatment, but per the RECIST criteria. Usually requires confirmation on a later scan, but it basically answers the question of did the tumors shrink meaningfully? And then next, you have the hazard ratio. So the hazard ratio, it basically compares the rates of an event occurring in two groups over time. So it essentially, at any given moment, how much more or less likely is the event happening in one group versus another? Cool. And then next slide, please. Awesome. So why dual ICIs versus TKIs? So the logic is clear. TKIs improve survival modestly, but don't fundamentally change disease biology. And side effects do accumulate. Immunotherapy, on the other hand, can create long-term immune memory. So responders may live much longer. Checkmate 9DW was designed to test this directly. Dual checkpoint inhibition against standard TKIs. Next slide, please. All right, handing off to Shiva.
Okay, so yeah, why Checkmate 9DW now? Where does this trial stand with everything that's been going on? So, as Dave mentioned earlier, tyrosine kinase inhibitors have not been standard therapy since about 2020, with the exception of certain patients with contraindications to checkpoint inhibitors, such as those with previous liver transplant with recurrence of carcinoma. The results of I Am Brave 150, which came out in 2020, were game-changing in the field of oncology because it established that atezo and beva clearly showed an improved overall survival compared to sorafenib. However, the major downside is the variceal bleeding risk associated with these two drugs. So for these patients who receive atezo and beva, a screening EGD is a requirement, which can be a rate limiting factor because not all facilities are equipped or have trained personnel to provide an EGD in a timely manner. And the next major update came in 2022 when the results of the Himalaya trial were released. This explored STRIDE, which stands for single tremelimumab regular interval durvalumab. And this revealed an overall survival benefit, even higher than that of I Am Brave 150 in terms of the hazard ratio, and it also showed an objective response rate of about 20%. And with that said, we also have to talk about certain negative IO-TKI trials, such as LEAP-002, which explored lenvatinib and pembrolizumab against lenvatinib and placebo. This did not meet its primary endpoints of overall survival and progression-free survival at final analysis. And Cosmic 312 explored the use of a TKI plus an IO. This trial met the progression-free survival, but there was no appreciable increase in overall survival, so it didn't really have much of an impact on practice guidelines. Camrelizumab, an anti-PD-1 antibody, and rivoceranib, which is a vascular endothelial growth factor receptor 2 antibody, was studied against sorafenib, but was rejected by the FDA for approval in the US. And so to summarize here, sorafenib was one of the only approved treatments for HCC for about a decade. And now we have multiple frontline options to treat advanced HCC, including durvalumab and tremi and other combinations for second line therapy. Next slide, please. So yeah, let's talk about some of these comparable trials here to properly frame the novelty of Checkmate 9DW. Multikinase inhibitors such as sorafenib and lenvatinib were first-line treatment options for patients with unresectable HCC for a very long time. However, they only provided a modest improvement in overall survival, which lasted maybe 12 to 14 months with unsatisfactory safety outcomes. So when PD-L1 inhibitor-based therapy received approval in 2020, which specifically were those drugs of the I Am Brave trial, and Himalaya then in 2022, these became the preferred drugs after showing improved outcomes over sorafenib, with a median overall survival rate ranging from 16 to 19 months. Atezo and Beva specifically showed a response rate of 30%, and Tremi and Durva showed a response rate of about 20%. But despite these advances in therapy over the past 5 years or so, the long-term prognosis for patients with unresectable HCC remains poor, and there's still a need to investigate alternative therapies. And if we look here at the first point A in Checkmate 040, this was the precursor phase 2 trial with nivo and ipi, which showed long-term efficacy and manageable side effect profile in patients with advanced HCC previously treated with sorafenib. This led to an accelerated approval in the US in this population of patients. Conversely, monotherapy with nivo in Checkmate 459 and tislelizumab, another PD-1 inhibitor in Rationale 301, did not show an overall survival benefit versus sorafenib as first-line treatment. And just to mention here, you should know your different phases of the clinical trial testing, phases 1 through 4, that's going to be on your boards. Next slide, please. So I don't want to get too lost in the weeds here. I really just want you guys to get the main point of the study here. So I Am Brave 150. This was also an open label phase 3 trial, which explored the efficacy of atezo and beva versus sorafenib in patients with unresectable HCC. So the co-primary endpoints were overall survival and progression-free survival. And the intention to treat population included 336 patients in the atezo and beva group and 165 patients in the sorafenib group. So if we look to the bottom here, this is like the main point of this slide is that the conclusion of this trial was that in patients with unresectable HCC, atezo and beva provided a superior overall and progression-free survival outcome than sorafenib monotherapy. Next slide, please. Yeah, same thing for Himalaya. I don't want you to get too into the details here. I think this was presented in one of the previous journal clubs. So STRIDE is also an open label phase 3 trial with similar enrollment parameters of patients with unresectable HCC and no previous systemic treatment. Here, patients were assigned to one of 3 treatment regimens, which included either a single high priming dose of tremelimumab, 300 milligrams, plus durvalumab, 1,500 milligrams Q4 weeks, which composed the STRIDE arm, or the experimental arm, or durvalumab, 1,500 milligrams every 4 weeks, or the last option was sorafenib, 400 milligrams BID. And the conclusion of this trial was that STRIDE significantly improved overall survival versus sorafenib and overall survival with durvalumab monotherapy, which was found to be not inferior to sorafenib. Next slide, please. So where does Checkmate 9DW fit into all of this? Now that we have a background understanding of the most recent trials, we can interpret where our most recent study fits into the context of Himalaya and I Am Brave 150. The overall survival ratio is nearly identical to Himalaya. However, it's worth noting that the median overall survival um, between studies cannot be compared. Additionally, all cross-trial comparisons are imperfect to some degree, so we should keep that in mind as well. The ORR, the objective response rate, is much higher with IPI and NIVO per RECIST criteria, which is likely due to the higher dose of CTLA-4 used in 9DW compared to the single fixed dose used in Himalaya. So there was predictably a much higher risk of immune toxicity as seen in the rates of grade 3 and grade 4 immune reactions. Um, of note, using IPI and NIVO is a way to reduce immune toxicity, which was established previously in studies utilizing renal cell carcinoma or lung cancer, but this was not tested in hepatocellular carcinoma. Next slide, please. Yeah, so let's talk about the study design of 9DW. It's, as we said before, it's an open label randomized phase 3 trial across 163 hospitals and cancer centers across 25 countries, including Asia, Australia, Europe, North and South America. And the study was conducted in accordance with good clinical practice guidelines of the ICH GCP, as well as the Declaration of Helsinki, which is basically a set of ethical principles regarding research involving human subjects. And the protocol was approved by the IRB, or Independent Ethics Committee, at each site, with ongoing monitoring with predefined definitions for relevant protocol deviations. And with that said, between April 2019 and February 2023, there were 2 protocol amendments that were made, which included statistical assumptions in order to preserve study power as the number of events increased. Next slide, please. Yeah, so the participants is something that we should talk about, especially the inclusion and exclusion criteria. The study included male and female patients aged 18 years or older with unresectable, histologically confirmed HCC without previous systemic therapy. And patients all had at least one measurable untreated lesion per RECIST version 1.1, a Child-Pugh score of 5 or 6, and an ECOG performance status of 0 or 1. So RECIST is a radiological criteria that stands for Response Evaluation Criteria in Solid Tumors. And it's a grading system that's used to objectively measure the response of a tumor to treatment. And the baseline scan, which would preferably be a CT with IV contrast and a slice thickness less than 5 millimeters, is done within 4 weeks prior to beginning study treatment. And target lesions are identified and measured using something called the sum of the longest diameter, the SLD. And now non-target lesions like ascites or pleural effusions that are not measured easily, but can also be followed or are also identified. And a follow-up scan done at a later time is used to compare the sum of the longest diameter of the target lesions, as well as look for new lesions and identify non-target lesions to determine whether there's a complete response, partial response, stable disease, or progressive disease. And that's really what this box to the left is alluding to here. And let's talk about the exclusion criteria. So patients were excluded from the trial if they had fibrolamellar or sarcomatoid carcinoma, mixed cholangiocarcinoma, previous liver transplant, episodes of hepatic encephalopathy considered to be grade 2 or more within 12 months prior to randomization, clinically significant ascites, main portal vein invasion, an active co-infection with Hep B and Hep C, an active co-infection with Hep B and Hep D. Next slide, please. Yeah, so we talked about RECIST version 1.1. So now let's address mRECIST. This is slightly different, and this was developed specifically for HCC because the presence of cirrhosis and the complex blood supply of liver tumors can make standardized size-based assessments misleading, and RESIST V1.1 often underestimates the response in liver tumors treated with local regional therapies such as TACE, Y90, radiofrequency ablation, or systemic therapies that cause necrosis rather than shrinkage. And the measure is based on a viable tumor response, not just shrinkage. So specifically, it focuses on arterially enhancing portions of the tumor, which would be identified on contrast-enhanced CT or MRI, and this would reflect viable tissue. The longest diameter of viable tissue is measured, not just the whole lesion. So it has the same measurement parameters, such as choosing 5 or less lesions and a max of 2 lesions per organ. And the response categories are the same as in RESIST V1.1. So include complete response, partial response, stable disease, and progressive disease. And the strength of mRESIST is that it is more reflective of the biological effect of therapy. Next slide, please. Just to touch on what Dave mentioned earlier about some of these definitions, ECOG stands for Eastern Cooperative Oncology Group, performance status of 0 or 1. To note, the patients that were included in this study had a performance status of 4 or 5. Sorry. And it's an indicator of how a disease affects an individual's ability to perform daily activities of living. And so a lower score is correlated to a better quality of life. And so 0 means that the patient is unrestricted in their ADLs, and 1 means that they're slightly restricted, but they can do light office or house chores. And 5 literally means that the patient is dead. And so Child-Pugh score is a scoring system that grades the level of cirrhosis mortality, which takes several values into account, including bilirubin, albumin, INR, ascites, and the level of encephalopathy. Child-Pugh scores can be useful in determining the prognosis of cirrhosis, but more recently, MELD and MELD sodium scores have become more widely prevalent given their better prognostic value. Next slide, please.
All right, so for randomization and assignment, so patients were randomly assigned to a 1-to-1 ratio via an interactive response technology system to receive nivolumab plus ipilimumab, followed by nivolumab every 4 weeks, or investigator's choice of either oral levatinib or oral sorafenib. Even though it's an open label assignment, assignment was centrally controlled via IRT with permuted blocks, which helps keep the groups balanced, and prevents foreknowledge of the next allocation. So randomization was stratified by etiology, whether hepatitis B, C versus uninfected, tumor extent taken into account, macrovascular invasion or extrahepatic spread, and baseline alpha-fetoprotein concentration of less than or greater than 400 nanograms per milliliter. These strata balance major prognostic drivers: viral status, spread, and AFP, so treatment effects aren't confounded by uneven risk. The primary endpoint was overall survival, which was assessed in all randomly assigned patients. Safety was an exploratory endpoint, which was assessed in all randomly assigned patients who received at least 1 dose of study medication. Next slide, please.
So I included this slide to really just give a better illustration of the treatment and control arms. So in the treatment arm, patients received nivolumab 1 milligram per kilogram and ipilimumab 3 milligrams per kilogram IV every 3 weeks for up to 4 doses, followed by monotherapy with nivolumab 480 milligrams every 4 weeks, or the investigator's choice of the control drugs of lenvatinib 8 milligrams daily or 12 milligrams daily. So this was dependent on the patient's body weight. If the patient had a body weight less than 60 kilograms, then they would receive lenvatinib 8 milligrams daily. And if their body weight was 60 kilograms or more, then they would receive 12 milligrams daily. Either that or sorafenib 400 milligrams BID. And treatment was continued until a level of unacceptable toxicity was reached. Patients withdrew consent, or for a maximum of 2 years, or disease progression. Um, Treatment beyond disease progression was allowed with clinical benefit if there was evidence of that. And there was also an important caveat that we should note here is that one or more combo doses were required before switching to nivolumab monotherapy if patients could not tolerate the therapy with both drugs. And this was determined on a case-by-case basis. Next slide, please. Okay, so let's talk about some of these dose adjustments and delays. So in the treatment group of nivolumab and ipilimumab, patients experiencing these adverse events related to combination therapy that did not meet treatment discontinuation criteria were allowed to proceed to nivolumab monotherapy dosing without completing all 4 combination doses. And so there were no dose escalations or reductions allowed for this group. However, dose delays were permitted for nivolumab, ipilimumab, or both due to adverse events. And patients receiving these drugs who had treatment-related adverse effects that met the criteria for dose delay had both drugs delayed until retreatment criteria was met, even if the adverse event was attributed to just one of those drugs. And if we look at the control group, dose reductions were allowed for the control group drugs of lenvatinib and sorafenib for management of the adverse effects. And this was based on the instructions provided in the approved product label and were considered for any severe or intolerable drug-related adverse events. And vice versa, the label-specific reduction or continuation criteria were also considered and applied before resuming treatment. If we talk here about the protocol, the tumor assessments were continued even if there were any dosing delays or interruptions. Next slide, please.
All right, so for PD-L1 testing, so for assessment of PD-L1 expression status, fresh or archived formalin-fixed paraffin-embedded tissue sections were stained for PD-L1 using a specific assay called IHC 20-28, as well as designated combined positive score, which is defined as either like the number of PD-L1 staining cells, can be tumor cells, lymphocytes, and macrophages, all divided by the number of total viable tumor cells times 100. Next slide, please. Okay. Oh, sorry. I read the wrong slide. Can you please go back to imaging and response rate? All right. So for imaging and response assessment, so tumor assessments were done by contrast enhanced CT chest, NCT or MRI of the abdomen and pelvis, including required triphasic CT or MRI of the liver, and all other known or suspected sites of the disease. Baseline tumor assessments were performed within 28 days before randomization, which is consistent with the RECIST criteria we spoke before. And patients were then evaluated for tumor response at week 9 from the date of randomization, at week 16, then every 8 weeks up to 48 weeks, then every 12 weeks until disease progression, treatment discontinuation, or initiation of subsequent therapy, or whichever occurred later. Next slide, please. And then I already read this too. Next slide, please. All right, so handing it off to Shiva.
All right, let's take a look at these results of Checkmate 9DW. So 668 patients were randomly assigned to receive either the treatment drugs of nivo and ipi or the control drugs of sorafenib or lenvatinib. And of the 668 patients randomly assigned, 657 of those patients were actually treated. And of those, 332 were designated to the treatment arm of nivo and ipi, and 325 were designated to receive the control drugs of lenvatinib or sorafenib. And it's important to note that of the 325 assigned to the control drugs, 275 of them received lenvatinib. So 85% received lenvatinib, and only 15% received sorafenib. And at clinical cutoff on January 31st, 2024, all 332 patients treated with the treatment arm discontinued treatment, and 310 out of 325 patients in the control arm group also discontinued the treatment. And so overall, this translates to 40% of the treatment arm and 69% of the control arm due to disease progression. And the median follow-up was at 35.2 months. And at this time, nivolumab and ipilimumab showed a significant improvement in overall survival over lenvatinib or sorafenib, which revealed overall survival of 23.7 months, favoring the treatment group. And in the overall survival at 24 months, 49% of those with nivo and ipi were favored against the 39% who received the control drugs. And overall survival at 36 months favored nivo and ipi again at 38% versus 24% with the control group. Next slide, please.
All right, so for the Checkmate 9DW overall survival curve, so it's not unusual for survival curves to cross early in the IO trials. There's always about 30% of patients who progress straight through the IO treatment. Early curve crossings, more early deaths from 0 to 6 months in IO, and then curves cross, then sustained separation favors IO thereafter. This effect is likely multifactorial. Although there's an early crossing, which means more early deaths on IO, the curve separate and stay apart thereafter. Median OS is 23.7 versus 20.6 months, and the hazard ratio of 0.79 with a p-value of 0.018 supports a real survival advantage for nivolumab and ipilimumab, driven by durable benefit after the first 6 months. Next slide, please. Okay, so among those who respond, nivolumab and ipilimumab responses last far longer. Their median is around 30 months, with many still ongoing at last contact, versus around 13 months on TKI. Pair it with the objective response rate to get the whole picture. IO has a higher objective response rate and longer duration of response, which means more patients with durable responses. Next slide, please. Awesome. So now for the statistical analysis. So the study was well powered with 650 patients randomized with a 1-to-1 ratio. Greater than 520 OS events were observed, which provided around 87% power to detect hazard ratio at a two-sided alpha value of 0.05. Interim analyses were performed, revealing greater than 416 OS events with very strict stopping rules. This was controlled for type 1 error using Landemann's alpha spending function approach using an O'Brien stopping boundary. The main comparison was to observe how long people lived in each group and to report a hazard ratio and a median survival. If the curves cross, backup methods were used that still compared OS fairly. Other outcomes measured included tumor shrinkage rate and how long it lasts, time until cancer growth or death, and quality of life assessments. The patients that were quantified for treatment efficacy included all randomized patients and anyone who received more than one dose. Cool. Next slide, please. All right, so for the safety, quality of life, limitations, and conclusion. So expect early risk window, which is the first 6 months, with IO before durable survival advantage emerges. Choose IO when long-term response is priority and you can manage the immune adverse events. TKIs remain reasonable when you need predictable dosing or expect interruptions or have high bleed variceal concerns. And the response and duration of response data above support downstaging or bridging discussions. So ultimately, the author's conclusion is IO delivers a meaningful, durable survival advantage with manageable safety, reinforcing it as a first-line option for unresectable hepatocellular carcinoma, while acknowledging an early risk window that requires careful patient selection and monitoring. Next slide, please.
Yeah, let's talk about how 9DW affected the 2025 treatment landscape and how that translates to oncologist preferences. So, if patients are eligible for IO VEGF treatment, most oncologists, as I understand, still prefer atezo and beva if the varices can be screened and managed, and if the bleeding risk is acceptable. If IO VEGF is not feasible due to not having access to EGDs or too much of a bleeding risk, then you would choose between Tremi and Durva and Nivo and Ipi now. And from 9DW, we know that Nivo and Ipi correlates to a higher objective response rate due to the higher Ipi dosage, but that also translates to a higher immune toxicity and adverse effects. And with STRIDE treatment, patients have lower CTLA-4 exposure, which means lower immune toxicity, but also a lower objective response rate. So you're kind of trading off the ORR for less adverse effects. And so long-term survival appears pretty similar across the IO doublets. Keep in mind that we have to avoid direct MOS cross-trial comparisons. And so if the patient is not an IO candidate for various reasons, then lenvatinib monotherapy would be the preferred option. Next slide, please. Awesome, and that concludes our presentation. Next slide. Thank you, everyone that came out. We really appreciate your time.
Does anyone have any questions about the trial they'd like to discuss? We have Dr. Brothers here, a hematologist oncologist from Loma Linda University.
Well, I can say that HCC, like pretty much every disease we treat in medical oncology, the treatment landscape has really just exploded over the past 10 years. When I started my hem-onc fellowship training, we had one treatment option, sorafenib, which we could tell patients this will help you live a couple months longer, but it's going to make you feel terrible. And it's not really going to shrink the tumor. And I would say the majority of patients with HCC, advanced HCC that is, elected against treatment. And so it was a huge game changer when atezo-bev came out in 2020, and checkpoint inhibitors. Well, they don't work for the majority of patients. I have a handful of HCC patients who are alive many years with metastatic disease, which we consider incurable, off treatment with no evidence of cancer. So it's truly miraculous. Atezo-bev still has the best overall survival data to date with the lowest hazard ratio. You should never compare cross-trial comparisons, but the pharmaceutical industry often doesn't like to do head-to-head trials in these cases, so we're pretty much stuck doing this. And so the best statistical measure to compare cross-trials is the hazard ratio because it takes into account the difference over the entire survival period as opposed to median overall survival, which can be affected by patient population. And it's just one time point where the 50% event takes place in the trial. But toxicity is real with atezo-bev. I remember when these trials first came out, these medications are pretty easy in other cancer types, much easier than sorafenib. So I had a patient come to me from UCLA who had just been diagnosed, and he saw this doctor over there named Richard Finn who recommended sorafenib, and I'm thinking, That's weird. Why didn't he talk to him about this new treatment that just came out? But the patient had a lot of advanced disease. We use BEV in colorectal cancer a lot. We hardly ever see bleeding. So I put the patient on atezo-bev, and he was in the hospital a week later with the major bleeding event. Because I thought the concerns about EGD screening were overblown. Richard Finn, by the way, is the first author on the paper for Embrave 150. So that was my mistake. And so the EGD screening is absolutely necessary. It takes a long time to get in GI in my institution, though, and many patients do have varices that can't be treated. So then we had the STRIDE regimen with Himalaya, which is a much more tolerable treatment, but lower response rates, lower hazard ratio. And where this ipi-nivo comes in is we do get higher responses, but similar long-term survival data. But the immune toxicity is much higher. We see about 20% immune events in PD-1 inhibitors, about 5 to 10% of which require discontinuation of treatment. But you can pretty much double that rate with when you add the IPI for 4 doses. Where the field is heading, you guys are interventional radiologists, or this is Interventional Radiologist Journal Club, not a medical oncology journal club, is how does this fit into your treatments? We've used a lot of local regional treatment in HCC, mostly because our systemic therapies weren't very good and the cancer stays in the liver for a very long time. So with patients with really advanced liver disease confined to the liver, we don't know what's best, doing lobar Y90 treatment or doing systemic therapy or a combination of both. We have one positive trial with combination TACE with durvalumab and BEV, the Emerald-1 trial, which has a PFS benefit but no overall survival benefit. There's a lot of trials ongoing, so I'm curious to see if moving these systemic therapies up earlier in lines of therapy or in earlier stages of disease leads to better outcomes. We have an adjuvant post-surgery study with atezo-bev, the Embrave 050 study, which was completely negative. After an initial PFS benefit, it disappeared at 12 months follow-up, and there was no overall survival benefit. What else? Treating sick patients. Many patients have really advanced liver disease that we see that don't match the trial inclusion criteria. And so the pharmaceutical companies want the best of the best patients so that they have the highest chance of showing a positive results. But most of my patients in clinical practice are B or C, Child's Pew score. These treatments work. They're safe, at least in Child's Pew B patients. But often as the liver disease gets more advanced, mortality is driven by the liver disease itself, the cirrhosis, rather than the cancer within the liver. So I'll pause here and see if there are any questions.
If anyone has any questions, you can feel free to put it in the chat as well. But we are coming up on the end of the hour here. I just want to say, like, that was an amazing and thorough presentation by Shiva and Dave. And we really appreciate the overview of all the trials and the current state of hem-onc and IR intersection. Thank you, Dr. Brothers, for coming and sharing your perspective on things.
You're welcome.